Hello everyone. Today we are going to speak about the last part of the gastrointestinal clinical pharmacology. Today we are going to speak about irritable bowel syndrome and irritable bowel disease. Okay, as I mentioned at the beginning, two topics will be covered in this last section of GIT, gastrointestinal clinical pharmacology, irritable bowel syndrome and irritable bowel disease. I'll start with the first topic, irritable bowel syndrome. What we have there in irritable bowel syndrome, we have the definition. Irritable bowel syndrome characterized by the chronic abdominal pain. So the patient suffers from abdominal pain, chronic abdominal pain. Okay, chronic abdominal pain and altered bowel habit could be constipation or diarrhea. So we are going to see patients suffer from abdominal pain with the constipation. We have the abbreviation for that IBC, IBS C for the constipation, IBS with D for diarrhea, or sometimes you can see both together like alternative habits. So we can see irritable bowel syndrome with the constipation, irritable bowel syndrome with diarrhea, or both together. We emphasize on the diet modification, psychological approach, and as a main important role in the management of irritable bowel disease. And at the end, we ended up with using the drug therapy. Okay, so what type of drug therapy we are going to use in this case here? You can see we have a dietary approach. Recommend patient to take a fiber, for example, here. Okay, with the fiber supplement improve symptoms of constipation and diarrhea for both constipation and diarrhea. Fiber, but some patient may suffer from high fiber food may cause bloating and discomfort. Another option here for the patient, polycarbophile such as citrocel and fibrocone may cause less gas and less disturbing to the patient. We recommend patient to avoid caffeine because associated with to reduce anxiety and reduce symptoms of irritable bowel syndrome. Also, we have some patients suffer from gluten sensitivity. We recommend patient to avoid any product that contain gluten on the ingredients. Okay, what is the first line therapy for IBS? First line therapy for IBS, if you can see here, it's like we target the symptoms here. If the patient suffers from diarrhea, we go the loperamide. We cover that in the diarrhea already. If the patient suffers from constipation, prescribe polyethylene glycol. If the patient suffers from abdominal pain, go with the peppermint oil and antispasmodic or antispasmodic. So diarrhea, loperamide, constipation, polyethylene glycol, abdominal pain, peppermint oil, and antispasmodic. So this is the first line treatment here. When the patient comes to the clinic, we try this group of medication. What about second line treatment? Second line treatment could be tricyclic antidepressant, SSRI, selective serotonin reuptake inhibitor, could be aloxadoline, this medication with a rivaxamine, two medication. If the patient comes to the clinic suffer from irritable bowel syndrome and diarrhea, we have aloxadoline and rivaxamine. However, if the patient suffers from constipation, we go with linaglutide, lobebristone, and gliglanatide, Tigasord, and so on. Cognitive behavior therapy has very effective beneficial effect in patients with the IBS. So this is a second line therapy. But if you go here, what we have the Medscape here, the link, eMedicine Medscape. If you click on this one and they take you to the website, Irritable Bowel Syndrome, I recommend everyone to go through this website and read the information about irritable bowel syndrome. Drug therapy, you can see the linaglutide here, for example. You can see lobebristone as a medication. We have here a list of medication can be used for the patients. Okay, so we discuss first line therapy, then we have second line therapy, then we have the medication here. So if you go there again, what we look on what we have, aloxadoline, rivaxamine, linaglutide, lobebristone. So we have here linaglutide. Okay, we have lobebristone. This medication used for patients suffering from IBS and constipation. So this one here. lopebriston, and linaclotide. Start with L for constipation. We have here, I will go back again to what we have. We have blecanatide, we have tigasord, we have lopebriston and linaclotide for constipation, diarrhea. We have eloxazoline and rivaxamine. Okay, now we have the question here. We take some time to figure out what is the correct answer for this one. Disease and irritable bowel disease. Okay, so you can see the picture here. You can see on the right side, ulcerative colitis mainly affect the colon and mainly affect the mucosa. On the other side, Crohn's disease mainly affect the any part from the intestine, large intestine, colon, but it affect the entire thickness of the colon. What else here? This one, for example, here compare between the Crohn's disease, ulcerative colitis. Another one here. So if you like to go in depth and read information about comparative study between Crohn's disease, ulcerative colitis, that will be great. Okay, so what we have here, as we discussed for the CB, for the ulcerative colitis, mainly affect the colon and rectum and mainly affect the mucosa. So the inflammation mainly limited to the mucosa. On the other hand, Crohn's disease may affect any portion of the GI system from mouth to anus and could be affect any part of the colon or intestine. Okay, medication used 5-aminosalicylic acid. So the main medication drug of choice will be sulfasalazine. Sulfasalazine, first line treatment for both ulcerative colitis and Crohn's disease. Sulfasalazine. Sulfasalazine, when the sulfasalazine prescribed, sulfasalazine considered like broad drug. So sulfasalazine broad drug, when the sulfasalazine prescribed to the patient, this medication broad drug will go to from the mouth to the stomach, intestine, arrive to the colon. So what happened here? We don't have absorption in the GI system. The medication arrived to the colon. In the colon we have bacteria. So you can see here we have colonic bacteria. This bacteria responsible for divided or cleave the sulfasalazine to the 5-aminosalicylic acid and sulfapiridine. Okay, the effect or the efficacy of this sulfasalazine related to the 5-aminosalicylic acid. 5-aminosalicylic acid give the effect or the anti-inflammatory effect, so 5-aminosalicylic acid. And the sulfapiridine, the another part responsible for some side effect. So side effect coming from sulfapiridine, but the efficacy, the effective of treatment coming from 5-aminosalicylic acid. Okay, so what we have here, first group of medication, first line therapy, 5-aminosalicylic acid. First line therapy for the ulcerative colitis and CD. Okay, next we can use cortisone. They said please remember short term for both because if you use it for long term, this will lead to the side effect. And remember, we have Cushing syndrome. Okay, Cushing syndrome is related to the overdose or long-term treatment with the corticosteroid. We don't prefer to make the patient suffer from Cushing syndrome. Okay, we have rectal formulation. In this case, that means we have fewer side systemic effect when you use it rectal. Local effect could be enema, could be like VOM for hydrocortisone or budesonide. Budesonide could be enteric release preparation. Enteric release preparation, this will arrive to the colon again. So when you have enteric release preparation, this enteric release preparation and with the delayed release budesonide, this will arrive from when you prescribe it oral, come from the oral to the stomach, intestine, and then arrive to the colon. In the colon will start working there, start the effect. Minimum side effect because there's no absorption in the GI system. Okay, then we have delayed release budesonide, and So delayed release, they said this medication delivers the drug to the terminal ileum, last part of intestine, and first part of the colon. So delayed release budesonide, and this medication used for ileocecal Crohn disease. Okay, we have patient here suffer 2 months history of abdominal pain, diagnosed with moderate Crohn disease, terminal ileum, and proximal large intestine. Which drug is best initiated in this patient? Extended, delayed, mesalamine, utoxinumab. Go to the slide here. Delayed release budesonide, terminal ileum. So the correct one, delayed release, will be the correct answer. Okay. Now move to the biological factors here. Biological factor, we have 3 main group. We have TNF-alpha inhibitors, we have alpha-4 integrin inhibitors, then we have interleukin 12-23 inhibitor. Speaking about TNF-alpha, I believe that this is already covered in the rheumatoid arthritis and psoriasis and the dermatology. So I refer the student or the audience to review the lecture about rheumatoid arthritis and psoriasis, because we already covered the biological factors. We have infliximab, adalimumab, we have citralizumab, golimumab, then we have this one belong to the TNF-alpha, then we move to the alpha-4 integrin inhibitors. So all these medications considered like inhibitor, as you can see here. Okay, for the alpha-4 integrin inhibitor, we have Entyvio, fadilizumab, used for both Crohn disease and ulcerative colitis. The last one here, Sterela and utoxizumab. This also used for both UC and ulcerative colitis. I will share with you maybe a few seconds from the commercial video about the Entyvio and Sterela. Now we listen to the record for the Sterela, utoxizumab.
For a flare-up.
Enough, Crohn's.
For adults with moderate to severe Crohn's or ulcerative colitis, Stelara can provide relief and is the only approved medication to reduce inflammation on and below the surface of the intestine in UC.
You getting on that flight? Back off, UC.
Stelara may increase
Okay, the second one about Entyvio.
Disease or ulcerative colitis, your day can be full of reminders of your condition. Never knowing. Always wondering. You weren't made for UC or Crohn's, but gut-focused Entyvio is. Entyvio works at the site of the problem to block certain inflammation-causing cells from entering the gut. Infusion and serious allergic reactions can...
Okay, so we already watched the two maybe videos about Entyvio and Sterela regarding ulcerative colitis and Crohn disease. Okay, next we have immunomodulators. Before we go further, please remember we have five. We have 5 aminosalicylic acid. Then we have cortisone. Then we have biological factors. Biological factors or agents. And the last one we have immunomodulators. Okay, so we have several groups could be used for the for the ulcerative colitis and Crohn disease. For immunomodulators, we have methotrexate, azathioprine, and 6-mercaptopurine. They try to remind us methotrexate is already mentioned in several places. Could be used for Crohn disease, cancer, rheumatoid arthritis, psoriasis. Methotrexate recommended monotherapy for Crohn disease, but not for ulcerative colitis. Please remember, Crohn disease not for ulcerative colitis. Azathioprine could be both. We use azathioprine and 6-mercaptopurine for both, and they are considered monotherapy for maintenance and remission for both disease. So immunomodulators. Okay, takeaway point for the IBS, IBD, aminosalicylate will be the first-line therapy. Aminosalicylate for ulcerative colitis, Crohn disease. Corticosteroid used only for short term to avoid side effect for long-term treatment. Immunomodulators such as azathioprine, 6-mercaptopurine, methotrexate, used for long-term maintenance. Biological agent, first-line therapy for moderate to severe IBD. Antibiotic could be adjunctive treatment for the patient. Question here, which of the following is the drug of choice for treatment mild, inflammatory bowel disease? Sulfadiazine, sulfasalazine, sulfapyridine, sulfamethoxazole, or salicylic sodium. All of these start with S. Which one is correct? So the correct answer will be sulfasalazine. This is the correct answer. Okay, moving to the next one. Here we have patients suffer from 55-year-old woman suffer from type 1 diabetes, and currently she is suffering from diabetic gastroparesis. Which of the following prokinetic drug that could be used in this situation? We need to enhance the movement of the GI system. Allocetrone, cimetidine, loperamide, metoclopramide, sucralfate. I'll start with the first one, allocetrone. So what is allocetrone? If you said allocetrone 5-HT3 antagonist, you are correct. And this medication used for IBS. But with what? Diarrhea or constipation? Okay. Cimetidine, we leave it for you. Cimetidine, H2 receptor blocker, and this medication used for peptic ulcer disease. Loperamide. Loperamide, what is loperamide? It's the mu opioid agonist, and used for patients suffering from diarrhea. Okay, not this one, not loperamide. Okay, sucralfate. What is sucralfate? Sucralfate, aluminum saccharose. Okay, and this considered like protective agent for the peptic ulcer disease. It's not for the IBD or gastroparesis. So the correct answer will be metoclopramide. So the question, what is metoclopramide? What do you think? What is metoclopramide? Okay, the metoclopramide considered like dopamine receptor. What do you think, agonist or antagonist? Dopamine receptor. If you said antagonist, you are correct. And this medication used for patients suffer from, okay, gastroparesis, diabetic gastroparesis. Number two, patients suffer from nausea and vomiting. Okay. What is the major side effect from the metoclopramide? If you remember that, very important side effect would be extrapyramidal effect like tardive dyskinesia, achasias, and other side effects. Okay, this lecture concludes our topic about gastrointestinal clinical pharmacology. In the beginning, we covered the peptic ulcer disease. Then we went through the GERD, gastroesophageal reflux disease. We discussed after that the nausea and vomiting, and then we explain in more detail constipation, treatment used for constipation. Then we spoke about the diarrhea, and the last topic was comparison and study the irritable bowel syndrome and irritable bowel disease. And we also review a lot of articles, a lot of pharmaceutical forms for the medication available in the clinical practice. I hope this series about the clinical pharmacology of gastrointestinal system or gastrointestinal tract provide you with a lot of benefit and maximize your information about the GI system. Thank you so much and have a great day, everyone.